Good morning. I was cleaning out old books over the weekend, and I came across one of my favorite authors. I couldn't resist. Anybody here read Dr. Seuss? And inside there was an insert, this piece of paper, which was a book that came out, one of his poems that came out in his obituary, actually. I thought it was relevant to the work that I'm about to present. My uncle ordered popovers from the restaurant's bill of fare. You know popovers, those of you who don't come from New York? And when they were served, he regarded them with a penetrating stare. Then he spoke great words of wisdom as he sat there on that chair. To eat these things, said my uncle, you must exercise great care. You may swallow down what's solid, but you must spit out the air. And as you partake of the world's bill of fare, that's darn good advice to follow. Do a lot of spitting out hot air, and be careful what you swallow. The field of health policy and management, as many other fields today, we're drowning in data. None of us can escape the bombardment of information all around us. We encounter expressions that are politically incorrect to question. Evidence-based medicine. Anybody in favor of non-evidence-based medicine? Evidence-based management, evidence-based policy, accountable care organizations. Anybody in favor of non-accountable care organizations? Healthy cities. Anybody like unhealthy cities? Age-friendly cities. Anybody in favor of non-age-friendly cities? So my advice to you today is indeed, be careful what you swallow. Now I'm going to illustrate this proposition by discussing the challenge of evaluating healthcare systems around the world. The World Health Organization, it's based in Geneva, introduced the idea of measuring health system performance, and we talk a lot about that at the Wagner School. And their report actually ranked about 190 healthcare systems around the world. Since then, the Commonwealth Fund right here in New York City, which has focused on 11 very wealthy healthcare systems in wealthy nations, also ranks 11 health systems of wealthy nations and asks rhetorically the title of my talk: why is the U.S. not the best? I'm going to speak to you about how would we know which system is the best. And it's a subject that covers many aspects about what I teach and about some of my research. One way of knowing, and it's a very important way of knowing these days, is simply based on beliefs and values. Indeed, many Americans would agree with former President Bush that the Americans have the best healthcare system in the world, and that's an article of faith. I submit to you that most Brits and most Canadians and most of the French would also have that same faith in their own healthcare system, and I have evidence to back it up. But beyond belief, how would we know which healthcare system is the best? Well, some people say it's all a matter of spending. If you look at the United States in 1980 as a percent of GDP, we spent more than any other country of the OECD countries, and that gap has only increased. We now spend more money than any country in the world, so some people would infer that we have the best healthcare system. We're resource intensive, we have everything here. People come from all over the world. Now the question is spending more necessarily good? Why do we spend more? Is it a price effect? Do we spend more? Most of the research suggests that we spend more because we have the highest prices. Is having the highest prices good? It's very good for people who work in healthcare. Those of you who get jobs in healthcare will have higher salaries. Doctors have higher salaries. Administrators have higher salaries. It's a booming profession. Overall, the evidence does suggest that we spend more because we have high prices, but also beyond prices, there's some work at OECD which looks, and I admit it's very hard, I'm racing through this, but beyond prices, we generally have more resources. Not in every dimension, but we're right up there with numbers of physicians, although not the most. We have a tremendous number of MRIs per capita, a lot of technologies, a large share of the population employed in healthcare. So we're a pretty fat octagon if you look at those graphs published by the OECD. We have a lot. But is that the way to measure a healthcare system? Maybe there are more appropriate or other criteria one should take in mind for assessing healthcare systems. Maybe we should focus on survival. Anybody here think we should focus on survival? How well does the population survive? Who's in favor of that? Hands, quickly. Okay. Our dean, Sherry Gleed, with whom you just met, has done a very interesting study which suggests that in 1975, the United States spent the least and had some of the lowest survival rates, and in 2005, 30 years later, spent a great deal more, much higher expenditure. You see the US there in the corner? I can't point to it. But also very low survival rates compared to other systems. So that's not so good. For those of you who said survival is important as a measure of the health system, I submit to you that it's not. It's not a very important measure of the healthcare system because the healthcare system only helps survive at the margin. There are too many other factors that account for survival. For example, there's a very important survey, 2016, from the Commonwealth Fund, which when you ask a representative population, does that say half? Okay. About whether they experience material hardship and whether they're stressed about being able to pay rent, mortgage, or buy nutritious meals, we come out the highest. That is the worst. A large 1/5 of the population suggests that there's a lot of material hardship. Now that may have much more to do with survival than the healthcare system. So in fact, the problem of judging healthcare systems based on survival or based on life expectancy at birth is that it violates the great equation: healthcare is not equal to health. It's only one dimension in producing population health. That's a major part of the Introduction to Health Policy and Management course. Our own Brian Abel, I don't know if he's here today, did a study with Elizabeth Bradley from Yale in which he compared the percentage of gross national product that we spend on health care and then looked at what we spend on social services, social care, old age pensions and support services for older adults, survivors benefits, disability, sickness cash benefits, family supports, employment programs. And on that score, if you look at the graph, you see that we spend the least as a percent of GDP on social care, even though we spend the most on GDP on health care. What other criteria should we look at to figure out if we are the best? Well, one other way, and it's been looked at by members of Congress over and over again, is to look at just survival from cancer. In this respect, we do very well. We have some of the highest survival rates of cancer. But is that the right metric to use to evaluate and determine what system is the best? The critics of this approach would suggest that the reason we have very high survival rates is because we have very early detection, and since we detect the disease earlier, people who have the disease live longer. So that may not be the perfect metric for assessing our healthcare system. So what do we do? What else should we look at? Well, here's a good intuitive way of looking at the question. You ask people, which the Commonwealth Fund did, are you confident that you will receive the most effective treatment if you are sick? And then you look at that by income, people above the median income, people below the median income, and you compare. On this scale, the United Kingdom and Switzerland have the highest gap between those below average income and above average income. And our overall confidence levels are not so high in the United States. They're much higher in the UK and Switzerland. Maybe that's the way to judge a healthcare system and figure out what's best. Another issue is access and financial barriers. If you believe that that's the key element, the most important thing about a healthcare system, you want to make sure that people don't have financial barriers, then we're doing very, very badly, because 43% of people below the median income express a cost-related barrier to healthcare, and 32% above the median income, that's people in this room, have financial barriers to healthcare. So how do we put this all together? Well, look at one more indicator, appointment times. A lot of people suggest that a good healthcare system, you shouldn't have to wait too long for an appointment, the same day or the next day. Look at the data from the Commonwealth Fund. There we're average. It's worse in Canada. It's much better in the Netherlands and New Zealand, Austria, Sweden, UK. The real challenge in this game is how do you take these discrete indicators and put them together to make sense and answer the question of what is best. And I suggest it's a very difficult task, and you must beware what you swallow in reading what's said about this. The World Health Organization put together a composite indicator which combines many discrete indicators and ranked the US system as 37. That infuriated people in the United States who were responsible for health care. But it may be true, but it may not be true. When we look at how the system was put together, it was published in the New England Journal of Medicine, which is a pretty reputable journal, and people took the study very seriously, which is why you should watch what you swallow. When you look more carefully at the study, it's based on 3 criteria. First, overall or average health. And I said we shouldn't judge a health system just on overall average health. We shouldn't even weight it very highly because health systems are only one factor contributing to overall health. The second criterion was responsiveness. Is the system responsive to the consumers? And the third criterion was fairness in the way it's financed. Well, they weighted the disability-adjusted life expectancy, the measure of health, 50%. It's a very biased way of looking at it. So I submit there were many problems. Let's look at how they looked at even responsiveness. It's a brilliant conceptual way to break down responsiveness. Respect for dignity, confidentiality, autonomy, prompt attention, quality of amenities, access to social support. But the problem here is that the survey they did was a convenience sample. If anybody did this in one of the Wagner classes, they'd be flunked out. They cross-examined, or they interviewed 1,000 people working for WHO around the world, and then they generalized about what different countries think. And it was published by the World Health Organization. That's another reason you should be careful what you swallow. The Commonwealth Fund looks at 11 countries and makes some of the same mistakes. They have some brilliant data. We send many of our graduates there, and they've done some very important work. But again, they have 4 criteria. They look at effective care, safe care, coordinated care, patient-centered care under the rubric of quality of care. Then they look at access, then they look at efficiency, then they look at equity, then they look at health, healthy lives. And they don't tell you how they weight these things, and then they come up with ranks. And there's 67 indicators, 5 criteria. It's enough to make you dizzy. But at the end, you get a rank. But what does the rank mean? I have a colleague in England, at the London School of Economics, who wrote a provocative paper on what I'm trying to say. He called it the folly of cross-country ranking exercises. Let's just assume that these numbers are right, that along the criterion of equity, responsiveness, cost containment, and efficiency, England ranks 9, 4, 7, 7. How would you create a composite score? You'd add them up, you'd divide by 4, and you'd get a score. Suppose the French look at this and say, we want to weight this different. Well, I mean, you would have to decide what the relative importance is of each one of these criteria. The English may weight equity very highly. They may weight responsiveness a little less highly. The French may look at this and rate responsiveness much more highly, and equity still highly, but cost containment less highly. So depending on how you weight the scores, which is often hidden, you get a very, very different result. Let me summarize, and then I'm through. How should we rank health system performance? How should we think about it? Should we think about it in terms of population health? Healthy populations have better health systems. They're healthy because of their health systems? I'd say no. Here's a few other ways of thinking about it. I'd love to think about it in terms of a health system which reduces the frequency of adverse events. I'd like to have a health system where there are no medical errors. I know in the United States 100,000 people die a year due to medical errors. But I can't compare it to any other country because no other country has a study comparable to that. So we have no data, so we eliminate that. What about the probability of survival when you're gravely ill? I would love to be able to rank a health system based on if I'm in the country and I'm gravely ill, my probability of survival is high. No data to compare health systems on that criterion. Waiting times, that's very important for some people. We have a tremendous number of data on that. But how do we make sense of that data? And who do we ask? Do we ask all adults? Do we ask chronically ill adults? Do we ask nurses? Do we ask doctors? Do we ask everybody? Do we ask people who are... And suppose you're waiting for something which is no good to begin with, then it really doesn't matter. But we do have some data there, and the Commonwealth Fund has produced a great deal, and we can study that. That has to do with the perceptions of the health system too, not just on waiting times, but on how it works on any number of criteria. Well, I've spoken to you about certain inadequacies, certain potentials. I now conclude on my two favorite indicators, and that would be first, something called amenable mortality. Rather than ranking health systems based on life expectancy at birth, look at the people who die who shouldn't die if the health system is actually performing well. That's a very important indicator, and there are studies that are looking at that today. On that score, we do very badly, I'm sorry to say, and our progress has been very slow. The final indicator I present to you is one that my colleague John Billings has devised many years ago, and that's called access to primary care based on what's called avoidable hospitalizations for things you should never be hospitalized for if you're well taken care of by the primary care system. For example, bacterial pneumonia, congestive heart failure, asthma, cellulitis. You shouldn't end up in the hospital for these things. So we can measure that in different countries, and I've done some international work which suggests in that respect that the United States comes out very badly. We have the highest rate of avoidable hospitalizations compared to England, Germany, and France, but we don't have data on other countries. Tried to give you some sense of that. These last two indicators I think are very important in answering the question of what is best in conjunction with a lot of the survey data that's available and in conjunction with explicit statement of what your values are and what the relative weights of different criteria should be. But everything I've said so far assumes that the nation state is the relevant unit of analysis. For those of you in urban planning, you know that's not always true. Much of my research has challenged that assumption and examines avoidable mortality, avoidable hospitalization, and healthcare systems in big cities. And that's what I'm working on for the next 10 years. Thanks very much for your attention.